So thanks very much, Dr. Samakar.
Of course, pleasure to be here. Hello to everyone. I am going to share my screen. Before I begin, does anyone by any chance know how to share screen in presenter mode? All right, I'm winging it, so bear with me then. Okay, can you see my screen? All right, well, thanks, Dr. Marks, for inviting me to give this talk. I am one of the general surgeons and specifically bariatric surgeon here at Keck. Pleasure to meet all of you. Today, I'm going to talk a little bit about a bunch of different topics. I'm happy to discuss during the presentation. So if you want to just chime in, feel free, or we'll save some time at the end to go over any questions you guys may have as well. I have no disclosures. So the first set of slides depicts the obesity epidemic in the United States based upon distribution of obesity rates. And back in 1990, you can see the vast majority of the country was rates, 15% or less. And as time went on, over 10 years, you can see that rates in the Midwest and South really exploded. You have rates of 20 to 25% obesity, body mass index as defined as BMI over 30. And then over the course of the next 10 years, you can really see the difference. Now we see rates of 30 to 35%. And up to 2018, we really see that this is a continuing trend, and it's quite alarming. This is a graphical representation of diabetes in 2018, corresponding to that last slide of obesity. And you can see really correspondence there. The term diabesity was coined about 30 years ago, and really it's become a disease, cluster of metabolic diseases that we're dealing with now: hypertension, physical inactivity, youth obesity. 75% of obese youth go on to become obese adults. In heart disease distribution, as well as poverty rates, there's a correlation with that as well. So if you look at a worldwide distribution, industrial countries really have a problem with excessive sugar consumption, and it's no surprise that global obesity rates in those industrial nations are prominent as well, but it is catching up to the rest of the world. So a few years ago, the AMA finally recognized obesity as a disease. They cited the abundance of clinical evidence identifying obesity as a multimetabolic hormonal disease state that increases the risk of other health conditions, including certain cancers, diabetes, heart disease, and more. So what causes obesity? Well, one quote I like is ancient genes in a modern world, but that doesn't quite explain all of it. There's certainly a genetic and physiological component. There's things that we cannot control, but there are things that we can control, like our behavior, our activity, our culture and society, the way we set up access to food, and the way we set up access in urban planning. But eating itself is a complex process. So there's a network of both peripheral and central mechanisms that guide what we crave, what we eat, how we feel, how we our energy expenditure and our intake. And these affect both our behavior, and our behavior affects them. So it's not simply a question of what we as bariatric surgeons often see, willpower. And that's classically what a lot of our patients have been told. Well, if you just eat right and exercise, that'll take care of the problem. So this is a study that was done about 20 years ago.
Lower the sound.
And in the dotted graph, you can see ghrelin levels. So ghrelin is an okay. I'm back unmuted. I'm okay.
Yes.
Okay. So
Sorry, Cameron, that was my fault. I was trying to mute everybody in the audience, and then unfortunately that included you. Apologies.
yeah, now you people use that button on me often. Don't worry. So the dotted graph below is ghrelin. Ghrelin is the hunger hormone, and naturally it corresponds to our feeding times. So at 8 a.m. you see ghrelin levels increase, and again at noon, then again at 6 p.m., corresponding to when we typically eat. And then the upper graph, the solid line, is ghrelin levels in patients that have lost weight. So patients that have gone on medically intensive diets, lifestyle changes, exercise regimens, and you note that it's the same graphical representation of when we have our hunger and appetite, but the ghrelin levels the absolute value has increased. And this is because the body has a barostat. And the barostat's really a pretty significant physiological driver of how we manage our weight. So, sorry, my slides are frozen. Let's see. Okay, so when we look into this, there's a pretty significant memory associated with adipose tissue. And when adipose tissue hypertrophies or decreases in size, that memory kicks in. And so there are mechanisms for us preventing us from gaining excess weight. There are mechanisms from us losing excess weight. Some patients, unfortunately, the hypertrophy aspect is the default condition. And if you look at the follow-up of the diabetes prevention program, you can see that the weight loss, associated weight loss, will typically diminish. And so everyone's seen this in popular culture, in shows like The Biggest Loser, where the weight that comes off almost universally comes back. But we know this, the yo-yo diet. This is the yo-yo diet. The vast majority of my patients have lost a significant amount of weight at one point or another through multiple, they've been on keto, Weight Watchers, Nutrisystem, paleo, whatever it is. It's not the problem of weight loss, it's the keeping the weight off. And there are significant physiological drivers for the weight to come back on. So swimming upstream is a real problem for patients who deal with severe obesity. What surgery enables patients to do is to have a tool that will help them maintain the weight loss that they can achieve. And if you look at this graph, it's the same graph we looked at earlier, where you have the dotted line representing ghrelin levels and normal controls, and then the solid line representing ghrelin levels after weight loss. Well, the very bottom line is ghrelin levels after gastric bypass. And that's what the hormonally mediated benefit of bariatric surgery is allows patients to actually have mechanisms that change to promote weight loss. So this is a representation of mortality. I mean, to simplify this, we know that mortality increases with weight. When you look at body mass index and mortality, the association with all causes of death is significantly higher, and it's a dose-related relationship. So this is the hazard ratio per 5 kilograms higher BMI. And so, as your weight goes up, your likelihood of death from this cause, these causes increases in proportion to that. So this has prompted large public health campaigns to mitigate some of the risks and to bring public awareness to obesity as a significant cause of mortality. Obesity is now set to overtake tobacco as the leading cause of preventable cancer, which is quite shocking when I heard that. And it's not just cancer in general. We know that it's associated with a significant number of different types of cancers, many of them the most common types, as well as the most common causes of death from cancer. And if you look at the increased risk, again, it's a dose-related increase. So this is a % increase risk of cancer per the Zoom here is cutting it off, per 1 kilogram increase in BMI. So you have a 2%, for instance, breast and postmenopausal women, you have a 2% increased risk in cancer per each 1 BMI above normal. And when you look at a meta-analysis of a pretty significant number of, this was, I think, over 200, again, I don't have my presenter notes, but this was funded by the Cancer Research Fund, and I think there was over 200,000 patients included. There was very strong evidence in this meta-analysis for most of the common cancers that we see. And why is that? Well, insulin resistance causes a whole host of problems, including cancer proliferation and a subacute clinical inflammation that promotes cancer genesis. So this inflammation both causes and is caused by obesity. So it's a vicious cycle of pro-inflammatory state leads to insulin resistance, which leads to hyperglycemia through diabetes, dyslipidemia, atherosclerosis, hypertension. These obviously all have effects on every organ system, but notably the central nervous system and impaired cognition, which leads to poor choices potentially. And so this cycle is hard to break. This is just another graphical demonstration of how obesity as a subacute or subclinical inflammatory state leads to increased tumor necrosis factor and IL-6, which can cause colon cancer progression as well as hepatocellular cancer. So a lot of our interventions are now aimed at weight loss for cancer therapeutics, potentially. This is a randomized Be-Well study. This is a randomized trial of weight loss in adjuvant treatment of overweight and obese women with early breast cancer. This is a UK obesity public campaign. Again, bringing light to this issue. And, you know, obesity doesn't just cause cancer. This is the cancer correlation is one that's not very visible, but obviously there's profound cardiovascular risks as well as other organ system malfunction. So what do we do about this? And going back to some of the stigma that we as bariatric surgeons fight and advocate for our patients against is the old adage of, well, if you just eat right and exercise. Eating right and exercising is the hallmark of any bariatric program. I mean, we have a dedicated dietitian, we have a dedicated lifestyle intervention, dietary program. Some of the very practical tips we give our patients, for instance, are not everyone knows they have a pedometer on their phone, but they do. And we ask them to check it every day. We ask them when they go out to the store to park at the furthest point in the parking lot, because the goal of 10,000 steps is not easily achievable by 8 p.m. saying, hey, I'm going to go get those 10,000 steps now. You got to break it up. But the reality of weight loss and exercise, and again, I'm not downplaying the importance. This is central part of our program. But we know exercise is good for muscle mass, cardiovascular health, bone density, mental health, but exercise doesn't cause weight loss. 95% of weight is determined by what you eat. And what you eat is often a complex thing. So when you look at the results from diet and exercise versus just diet alone, they're very modest. 6 kilograms after 1 year of intensive diet and exercise, average in multiple studies. There's a 95% failure. This has been corroborated multiple times. Patients with a BMI over 95 put into a weight loss behavioral change program, it doesn't help. Now, unfortunately, the failure rate is too high. And although it may work, in theory, for all practical purposes, this is a failed treatment strategy. If you look at intensive medical therapies, lifestyle interventions versus what you see at the top is MT, medical therapy, lifestyle, LI, lifestyle intervention. LAGB is laparoscopic adjustable gastric band. The next comparison is room-wide gastric bypass. And then the last one is medical therapy compared to vertical sleeve gastrectomy and room-wide gastric bypass. This is rates of weight loss, percentage of weight loss at 1 year. And you can clearly see even the worst, the gastric band option that we have is far superior to medical therapy lifestyle intervention. If you look at some of the best studies that have been done on high intensity lifestyle interventions and pharmacotherapy intervention, the results are pretty modest. You know, after a year of in the Look Ahead trial, you have about half of the participants have lost just 5% of their weight, and that's really not enough. Patients with BMIs of 40, 5% is just not enough. And even the pharmacotherapy, you have pretty modest results. Now, these are still, again, central parts of our program. But for our patients, you know, BMIs 35 and above, this is inadequate therapy in our opinion. So I'm going to transition now to our the surgeries we provide and how we choose them and what the right options are. But before I go there, I want to talk a little bit about the history of some of these surgeries that you've seen in your clinic, some of your patients have had, and a little travel back in time here. So the jejunal ileal bypass, one of the earliest, really extremely good weight loss, you know, bypassing the vast majority of the small bowel. Patients ended up in liver failure with multiple organ issues, really malabsorptive. This was, you know, the importance of this operation was that that showed that there could be profound changes from bypassing the intestine, but this was not the way to do it. The vertical banded gastroplasty, it looks almost like a sleeve, but it was actually something a little bit different. It was a combination sleeve bypass. This had a really high complication rate, as that, you know, I still see some of these patients come through with that celastic band that is eroded into their stomach. And then the biliopancreatic diversion. This operation is still being done in the United States, fairly less, I would say less than 1%. Extremely good diabetes resolution. You know, we're talking about upwards of 95% diabetes resolution. But again, a lot of malabsorptive problems, a lot of iron anemia, excessive diarrhea. And so really moved away from this. And then the gastric band, notorious. Everyone here has probably seen or has patients with the gastric band. Full disclosure, I've never placed a gastric band. I've removed hundreds at this point. These are some of the complications that we see from gastric bands. This is what you're seeing, that bubble at the top is the top portion of the stomach has slipped up above the band where it shouldn't be. And the band is basically causing ischemia to that portion. This is an endoscopy of a gastric band that has eroded through the stomach and is now intraluminal. This is a upper GI. You can see the band as the last device there, kind of horizontal at a 45-degree angle. And then the esophagus, you can see, is very tortuous and dilated. And there's a lot of end stage disease with the esophagus in our band patients. So, you know, the band, I would say at this point, over 80% have been removed or revised at some point. And so really, that's not an option anymore. Gastric bypass, this is one of two of the most common types of procedures done in the United States. It's definitely a minority compared to the sleeve gastrectomy. The gold standard, still in my opinion, in terms of weight loss and comorbidity resolution. A small gastric pouch is created. The remainder of the stomach is separated and the intestine is connected to that pouch. You have excellent weight loss results. So when we talk about weight loss in bariatric surgery, we talk about excess weight loss or total weight loss. So to give you a representation of what excess weight loss is, if you are a 5'2" female, based on the Metropolitan Life tables, BMI of 25, your ideal body weight is 135 pounds. If you're 235 pounds, that means you're 100 pounds over your ideal body weight. That's your excess weight. And the gastric bypass in multiple studies delivers on average 70 to 75% excess weight loss. So if your excess weight is 100 pounds, that's 75 pounds. The other way to think about it is total weight loss. And that's probably the better way to think about it. But these numbers are relevant when we talk about how do we decide what's right. The sleeve gastrectomy, the most predominant operation done in the United States and worldwide at this point. About 75% of the stomach is resected, and you have weight loss similar, but not as good to gastric bypass. But if you have an excess weight of 100 pounds and you can get 60 to 65 pound weight loss average with the sleeve versus 70 to 75 with the bypass, without nearly as many of the short and long-term risks, a lot of patients will opt for this procedure. And so how do they work? Well, the gastric bypass has a malabsorptive component as well as a restrictive component. The gastric pouch is restrictive, the bypass portion is malabsorptive. The sleeve gastrectomy only has the restrictive portion. However, there are hormonally mediated effects of these procedures. And a lot of those are related to the gastric and the pancreatic hormones, ghrelin, leptin, GLP-1, peptide YY, and insulin. And so these mechanisms are what mediate a lot of the weight loss. And that's also what mediates, for instance, the diabetes resolution almost immediately or improvement post-sleeve gastrectomy. There's no bypass portion, but it's the hormonally mediated, non-weight dependent aspect of sleeve gastrectomy. This is just a representation of what types of surgeries we do over time. And you can see that, the lap band was nearly 40% in 2010, and it's essentially not done anymore, versus the sleeve gastrectomy, which has really taken a significant amount of the volume. So talking a little bit about mortality, this is the BOLD database. This is published in 2018, 150,000 plus operations. 30-day and 1-year mortality for bariatric surgery is fairly low. This is 0.13% and 0.23% mortality. And if you look specifically at bypass versus sleeve, the mortality of a bypass is slightly higher. However, leak rates remain less than 1%. PEs are obviously less than 1%. Hemorrhage can occur in about 1%. Subclinical hemorrhage is the vast majority of that. Return to OR for hemorrhage is extremely rare. And 30-day mortality as well as 1-year mortality is low. These are some of the studies regarding the benefits of bariatric surgery. Specifically, this one is in regards to diabetes. You can see in the middle, remission rates after bariatric surgery are roughly around 50% for diabetes. And if you are interested in the effects, there's multiple studies. I mean, the benefits of bariatric surgery on diabetes are very clearly established. At this point, what we're really looking at is the metabolic effects. So surgery, non-weight dependent bariatric surgery on diabetes and comorbidity resolution. So this is in type 2 diabetes in patients with body mass index lower than 35, effective bariatric surgery versus medical therapy. And again, surgery has profoundly better results compared to medical therapy. This was a study that was done on that same study that I just presented, and this is the details. So if you're interested in those, you can see the surgical group on the left and the medical group as well. And the diabetes duration is important because patients with long-standing diabetes seem to have lesser resolution rates, but still significant improvement. These patients had an average BMI of 29 in the medical arm and 31 in the surgical arm. Their hemoglobin A1C difference was significantly better after surgical and medical therapy. However, there was better results in the surgical group. And you can also see that how you define diabetes resolution, whether you use A1C, whether you use insulin use, any diabetic medication use, there were still differences between the medical and surgical group. going to skip this one. So what are some of the things we worry about? So as internists and primary care physicians, you will have patients that have undergone surgery, and you will have patients with bypasses and sleeves, or patients that come from elsewhere with duodenal switches and gastric bypass. So the bypass does have complications, marginal ulcers. Rates of marginal ulcers, which is an ulcer at the connection between the stomach and the intestine, occur. And these are typically due to foreign bodies. There are people in the community, in the world, that quite frankly don't know what they're doing, and they use non-absorbable sutures that represent a foreign body and cause ulceration there. This could also be behavioral, smoking, and NSAID use. So gastric bypass patients should really not use NSAIDs because of the ulceration rates. And smoking cessation is critical. So we have a smoking cessation rule prior to bariatric surgery. Internal herniation can occur, especially in gastric bypass, because of the small bowel, and that'll present with typically acute onset of pain. So if a patient presents with a gastric bypass as a significant abdominal pain, sure, they can have the usual gallstones, appendicitis, diverticulitis. But after a gastric bypass, we always have to consider internal hernias. And the rates of those are about 1%. Dumping syndrome, there are some estimates that suggest dumping syndrome as an occurrence can happen up to 50% of patients. Typically, patients with chronic dumping syndrome are very rare, and that's just because of excessive simple carbohydrate consumption. Due to the high osmolality of simple carbohydrates, they can have basically a sympathetic response, hypotension, tachycardia, nausea, dizziness, fainting, and 95+% of dumping syndrome can be controlled with just behavioral dietary changes. Stomal stenosis related to marginal ulceration, again, can be secondary to smoking, NSAID use. Cholelithiasis, weight loss can generate gallstones. We used to prophylactically remove everyone's gallbladder at one point in time. We don't do that anymore. Ursodiol has been shown to decrease gallstones, but we don't typically use it just because it's not very effective in the side effect profile. Cholelithiasis occurs, the generation of gallstones occurs probably in about 25% of post-bariatric patients, but only about 20% of those patients go on to be symptomatic. So if they do, they may need their gallbladder removed. Small bowel obstructions and intussusception are related, and these are related to almost any kind of intra-abdominal surgery we do, but the rates are fairly low. And really rare incidents like postprandial hyperinsulinemic hypoglycemia or nistidoblastosis can occur, especially with or only with gastric bypass, where you have hyperinsulinemic hypoglycemic episodes. And some of these patients ultimately do need to go on to have reversals of their bypass. The sleeve gastrectomy, the reason it's popular is because it doesn't have nearly as many of those complications. Now, although those complications are rare, and as I showed you in the previous slides, the mortality from them is pretty insignificant. They do occur. Now, sleeve stenosis, we use what's called a bougie. It's essentially a stencil. It's a rubber tube that we place in the stomach when we create our sleeves to prevent narrowing, especially at certain angles that we know are prone to that. Leaks occur less than 1% of the time. I think the statistic we looked at was about a third of a percent. And reflux. So we have a very hard time knowing who. So let me start here. The vast majority of patients with reflux will have improvement or resolution of their reflux with weight loss. There is a subset of patients that may not have improvement or resolution. And there's a subset that may have worsening reflux symptoms after surgery. It's very hard to predict who those are. Typically, patients with an associated hiatal hernia, we really do a pretty good job of evaluating that hernia and deciding whether or not it should be fixed at the time of sleep. And patients with intractable or breakthrough symptoms, despite optimal anti-secretory therapy with reflux, I will recommend that they proceed with gastric bypass rather than sleeve gastrectomy, because I know that the gastric bypass is going to be more effective for their reflux symptoms. Postoperative care for our program, obviously, we're an accredited comprehensive center. We have routine scheduled follow-ups at 2 weeks, 2 months, 6 months, 9 months, and yearly. patients can see us anytime outside those. Alongside those, we have our support groups monthly. We have telemedicine. But I think in conjunction with our medicine colleagues, what's important for us to communicate is we're always available. So whenever something's going on that may be related to that, I think that communication is key. We will routinely order multivitamins with labs. Now, you all may have patients that are not enrolled with us, and you may be managing that. And all that is essentially a panel of vitamins and micronutrients, such as the B vitamins, calcium, vitamin D, to make sure that our patients are not having nutritional deficiencies. It's fairly rare to have a nutritional deficiency with a sleeve, but in bypass patients, it can happen. We recommend our patients abstain from alcohol, tobacco, and NSAIDs. We did publish a paper, one of the first that identified similar outcomes in NSAID use for sleeve gastrectomy patients as normal population. So we have lifted that recommendation for our sleeve patients, and limited alcohol use is considered safe. It's just that post-bariatric surgery patients are prone to have really low tolerance to alcohol that can get inebriated very fast. And then medical management. So diabetic patients, if a patient comes in with 1 or 2 metformin and maybe an oral medication, we will stop the oral medication prior to discharge. If they're on multi-medications, we'll typically have an endocrinology consult. But our concern here is less hyperglycemia and more hypoglycemia in our post-op patients. The effect of bariatric surgery on diabetes is very rapid and very profound. And so as internists, I think that would be something that would be important from our perspective to share with you. Hypertension is the last obesity-associated medical problem to improve. Hyperlipidemia and obstructive sleep apnea are mid-range. And so typically by 3 months, I'll ask my patients, I would check with your PCP about when you can try coming off your CPAP or stopping your statin. But typically for the statin, we'll have objective results at the 3-month mark with their labs to see if they're normalizing. And if you look at the various obesity-associated medical issues, you can see the far right columns are improved or resolved. Diabetes improved or resolved 100%. Hypertension, similar results. Hypercholesterolemia. So I want to transition over to some of the things you may have heard about for the treatment of severe obesity that I can maybe shed some light on. So endoluminal interventions, what are they good for? So what are the advantages? You don't have to have surgery per se. And it's presumed to be lower morbidity. Whether or not it is has not been borne out, and sometimes it is not. What are the disadvantages? Unknown durability. So we've been doing the sleeve for 20 plus years, the bypass for 50. Some of these less than 1 year, most of them less than 5. It's technically difficult, hard to reproduce, and the weight loss efficacy versus the comorbidity resolution are some of the disadvantages. So who are candidates? Patients that don't want surgery. Sometimes that is an irrational thought process that we just have to counsel patients on where that comes from. Sometimes it's a rational thought process. They can't have surgery or it's high risk for them. As a bridge temporizing measure, marketing. A lot of these endoluminal procedures are heavily marketed, and I'm sure you've seen that yourselves. And revision, patients with weight loss failure or weight regain. So aspiration therapy, this is pretty much a joke. It's essentially a PEG tube. Patients after 30 minutes after ingesting food aspirate into the bathroom, the contents. I would not recommend this to anyone, obviously, but it is something that is out there. And, in pivotal trials that were done on this, the severe adverse events was fairly high and the total weight loss was fairly low and pretty significant complications. Barrier liners, this is essentially implanted into the small intestine, the first portion of the small intestine, and prevents absorption through that portion. And there's different barrier aligners. This is a visual representation of what it may look like. In their various lengths, 60 centimeters, 120 centimeters. Early removal is very common, high adverse events rates. And, you know, the trials in the US were actually halted because of the high adverse event rate. This just goes through another study which showed why we shouldn't be doing things like that. Balloons. So this is probably one that everyone here has heard about. Probably some of your patients have asked you about. Various balloons on the market. Single balloon, multi-balloon, balloons that you swallow a pill and inflate on their own, or have a catheter, balloons that you inflate with saline, with air. This is meant for class 1, class 2 obesity, essentially patients with BMI 30 to 40. It's temporary and reversible. Temporary is not an advantage when it comes to obesity. You really need durable and long-term non-reversible, but the advertisements, this is temporary and reversible. I'm not sure why anyone would want to, but it's because of the lifespan of these devices. They need to be removed. There's a high cost. This is not covered by insurance, and the cost ranges somewhere between $6,000 and $15,000 per session. So at 6 months, if you have your balloon removed or balloons removed, you have to repay to have new balloons placed. Weight gain after removal is very common, and weight loss. Again, remember the bypass had about 30-35% total weight loss. Sleeve had about 25, and these have about 6 to 15. So pretty inferior results. This is results from the randomized controlled trials. These are total weight loss at 6 months. And so this is their best weight loss, because once they're removed, their weight regains. And you can see it's pretty modest and really not worth either the financial or the fact that once it's removed, the weight will presumably return. And we've seen this. The gastric band patients have near universal weight regain after their device is removed. These are some of the adverse events: vomiting, nausea, abdominal pain, and pretty high rates. I mean, we're talking about more than 50% in some of these. Duodenal mucosal resurfacing. This is interesting. We're actually part of a multi-center trial at USC looking at duodenal mucosal resurfacing. And the thought process here is that resurfacing. So we do something similar for Barrett's of the esophagus. We ablate that mucosa, and the new mucosa that's regenerated is potentially could be free from Barrett's. Duodenal mucosal resurfacing is a similar concept, where essentially we burn the mucosa of the duodenum, and we see pretty significant diabetes resolution. And so in a pilot study of nearly 40 patients on oral diabetes medications, there was an absolute reduction in hemoglobin A1C of 1.2%, but minimal weight loss. If you have any patients with diabetes that are interested in enrolling in this trial, we are part of a multi-center trial looking at this for the treatment of diabetes. So gastric plication and suturing. These are devices used to sew the stomach from the inside. So go through the mouth, go down the esophagus, enter the stomach, and use. This is one device. This is another device, the USGI incisional. And what do we do with that? Well, endoscopic sleeve gastroplasty. This is being done really it's being done at USC. It's being done at really academic centers. It has not had widespread adoption. It's being done by people who are specifically trained to do this. And so the results are not from widespread adoption. Essentially what it is tries to recreate a sleeve endoscopically. Now that tissue remains, but the lumen of the stomach is much smaller. It's an endoscopic procedure using general anesthesia, full thickness sutures, and the mechanism is essentially narrowing the lumen. And so you can see these are spots where the sutures are taken to create a much narrower stomach. So the results on this are promising for certain patients. However, not as good as traditional bariatric surgery. So 8 observational studies here with a mean percent total weight loss of 15, 16, and 20. Again, 25 to 30 for sleeve, 30 to 35 for bypass. and serious adverse events were 2%. In comparison to bariatric surgery, which is less than 1%. They did have no mortality, however. When you look at the pooled percent excess weight loss for these procedures, it's about 15 to 20% total, and that's across multiple studies. There are pretty significant adverse events such as bleeding, perforations requiring exploration, pain post-procedure, the gamut of dehydration, nausea, vomiting, etc. So a systematic review was done on ESG. Most case studies are small. The largest ones are done at single institution centers, which it's very hard to extrapolate data from single provider or multi-provider at a single center. The existing literature is pretty poor, and the case reports show promising but inadequate weight loss. 5-year outcomes, again, this is single center, same endoscopist. 5-year total weight loss is 16%. And so, and these are some of the post-procedure related issues with ESG. Patients needing pharmacotherapy for weight loss, weight regain, and 25% have adverse events in terms of such as nausea, pain, constipation, heartburn. There was a comparison of sleeve gastroplasty, the endoscopic, the laparoscopic sleeve gastrectomy, and the laparoscopic greater curve plication. So the laparoscopic greater curve plication is essentially the endoscopic sleeve, but done laparoscopically. So instead of resecting that portion, such as in the sleeve, you just sew it from the outside. So in this study of 300 patients, looked at total weight loss and safety of 2 years. At 2 years, the endoscopic sleeve had 18% weight loss. The sleeve had 28%, and the laparoscopic gastric plication had actually pretty good results, although we don't favor that procedure just because we don't think it gives you as much of the hormonally mediated benefits as the classic sleeve. So the advocates for bariatric surgery are across the board. American Diabetes Association, International Diabetes Association. I mean, even the IRS has something to say about this. We all know that. But you know, despite the fact that 20 million adults are eligible for bariatric surgery, these are the numbers. We do less than 200,000 cases in the United States. You know, as a bariatric surgeon, obviously I'm compelled to advocate for my patients. I'm compelled to advocate for patients struggling with obesity. I think surgery is a tool and it's a last resort. I don't think it's a first resort, and I think patients need to have exercise and lifestyle programs in place. They need to have medical management of their associated comorbidities, but they need to also be informed of the options available to them. And obesity as a disease can be treated. So less than 1% of all eligible patients undergo surgery. These are some celebrity profiles after bariatric surgery. And you know, these pictures, you know, they're great and they're not great, right? Because we're focusing on what people look like, and that's really not the intent here. It's their health. But at the same time, how people feel and how they look is really a determinant of their health as well. And when you're able to promote weight loss in patients, they're able to engage in things that perhaps they weren't, and they're able to engage in sports. They're able to engage in family time. They're able to engage in activities with their children, grandchildren. And there's an effect on the family as well. The multiple studies have shown the weight loss effect on families of patients who undergo bariatric surgery. So that concludes my slides. I'm happy to take any questions.
Thanks, Kamran. That was a great review. I certainly did not know there were quite so many options, surgical options. Some more invasive than others. Does anybody in the audience have questions, feel free to just unmute. If you prefer, feel free to type into the chat. Aaron asked, for patients who undergo a sleeve, if it ends up not being sufficiently effective, can they have, let me see if there's more there or if it just.
A bypass later on, yeah.
There we go. Yes.
Yeah, so we define weight loss failure after bariatric surgery as less than 50% of excess weight. Now, that's not based necessarily on anything physiologic, but in the literature, that's how we define it. So if patient has 100 excess pounds and they lose less than 50%, two things have to happen. A, we have to really inquire as to, are they complying with the diet, behavioral, lifestyle recommendations? So you can defeat your sleeve if you decide, hey, I'm just going to eat horribly. Now, if a patient's been doing their best and they've had insufficient weight loss, yes, they can be converted to bypass. The literature on that, however, is not great. The patients who fail sleeve will have modest benefit from conversion to gastric bypass, and they have a very high complication rate as compared to primary. So we do not advocate for it, but I always see patients who want to see me for that reason. And I just talk them through, should we refer you to Dr. Hong, who I'm sure all of you know, for medical management of weight loss? Should we restart you on the post-diet bariatric program and see what kind of results we can get? And as a last resort, if they truly fail and they've done everything, we will convert them. What are insurance company barriers? Almost none. All CMS covers bariatric surgery. They have the least requirements, and almost all payers have come into compliance with that. We have contracts with nearly, I don't know who we don't have a contract with. So BMI of 35 with comorbidities. Now, that is a very loose target, because the vast majority of patients we see who do not have a documented obesity-associated medical problem just don't have it documented yet. And so we do a complete metabolic panel. We talk them through things. We do a sleep study if we have to get it justified. And in the United States, there's a strong push for metabolic surgery, which is BMI over 30. These recommendations typically come from the 1991, 30 plus years old NIH criterion, which at that point was almost arbitrary. The American Society of Metabolic Bariatric Surgery now has adopted their own guidelines, and those are being supplemented by the International Diabetes Federation, as well as other societies to change these guidelines. But it's currently 35 plus some comorbidities, or 40 without. The newer agents, 33% weight loss in 50% of folks on even middle doses. Yes. Yeah, I'm all for it. I think, we need to investigate these more. The problem is patients who are 40 years old with a severe obesity, BMI of 50, that may not be enough weight loss. The other problem is adverse events. People discontinue these medications. The other problem is people don't want to be on medications for 40 years. So I think all of these things need to be investigated. I work with Dr. Hong, and I send him so many patients and vice versa. And it's all about what is the best, how can we serve these patients best? So I think that will the day come that we have a medication that gives us 70% total weight loss and is low cost and well tolerated? I'll be all for it. No problem, no question about it. But we are not at that point right now.
Just a reminder to the audience, if you want CME credit, we're being fancy now. Please dial the number and enter 5161 for the code. I actually have a question, Kamran. I've had a number of patients undergo bariatric procedures, and it seems like things are going great for a few months, 6, 12, even longer than that after the procedure. And then almost universally, it's been my experience that they plateau, and then it's a struggle from there. What can I do to help them? What can you do to help them past that plateau point?
Yeah, I see it too. So let me hit on a couple of things. So if you're talking about short term, but 35,000 view point. So a if you have a patient at the age of 30 and you track their weight to 40, I'm not talking about bariatric patients, you will classically see weight gain in that decade. Some of our weight gain patients are just having weight gain because that's what happens. The course of life changes, metabolic changes occur. Some of our patients lose a profound amount of weight, then they plateau, and that plateau usually hits around 1 year, 18 months. And then they start to regain weight. What is that regain weight? Well, about 20% of patients will have about a 20% weight regain. And what could that be attributed to? Well, maybe they're just not adhering to that. They're not as motivated as they once were. They had good results. They took their foot off the pedal and they just need to restart that engagement. Maybe it's just life, and weight regain happens. Maybe it's that their sleeve has dilated and that's causing less satiety. It's multifactorial. We have a very poor follow-up rate in bariatric surgery across the board. Patients just stop coming to us, even though we try to advocate for at least yearly follow-ups or yearly support groups. The patients that do the best are the ones that continue to be engaged. And why do they stop being engaged? Is either because they're successful and they stop and then they weight regain and it's hard to get back, or they're not successful and there's a certain embarrassment or they don't want to be seen as not successful. So one thing I would say is, if you do have patients, I would say, hey, have you checked in with them? We love to see our old patients, even patients that have regained weight, because we want to know why, and we want to engage them. And some of these agents that Dr. Orange pointed out, some of these may be of benefit to them. So a combination therapy, medical management, as well as lifestyle interventions, as well as re-engaging our dietitians, our support groups, the lifestyle things. This is a lifelong process. So the surgery is not going to be a magic, silver bullet, but you should be able to have meaningful weight loss for, even if it's temporary, for a significant amount of time.
Does anyone else in the audience have other questions for Dr. Samakar? If not, I have one final sort of big picture question that I feel like a lot of patients are picking up on lately. I don't know why, if it's maybe been in lay press or something, I'm not sure. The issue of use of the BMI, it just seems like there are so many pitfalls with that approach to measuring obesity. Muscular guys, pendulous breasts, what have you. It doesn't, please comment.
Yeah, so it's interesting, when you, it's a problem. It's a problem. A, let me just say, yes, it's a problem. B, we don't have anything better that's universally adopted. C, all the insurance mandates and CMS policy goes off of that. It's very hard to create a system that is not based on BMI. But yeah, you're absolutely right. So when you look at the WHO's guidelines on what qualifies Indians in India for bariatric surgery, they're different because the Indian population has a higher adiposity distribution for their BMIs, and they have more central adiposity, and they have higher diabetes rates as a result. So people are essentially using a system of common language, BMI, and changing it for various populations because it's an imperfect system. And so we're kind of stuck for now, unfortunately. But I share that sentiment with you. And we even in our own scientific community, a lot of people still use excess weight loss, where multiple studies have shown probably total weight loss is the better standardization across systems. But if I could change it, I would.
Future direction. Invent something better.
Okay.
Okay, great. Final, I think we have an applause from Dr. Turner. Yes, and I second that. Thank you for a great talk. I have a few patients in mind that I feel like I have been remiss in sending you, and we'll do the next time I see them. And I appreciate your great talk and helpful information.
It's my pleasure. I'm happy to do it. And if there are patients that you've had that have had bariatric surgery that want to reestablish care, never established care with us, we're happy to see them. We're happy to see new patients. If you have any issues, USC Care, unfortunately, is not the best way to make appointments with us. So if you have any issues, you can always shoot me an email. I'm happy to accommodate.
Fantastic. Thanks so much. Have a